Thank you very much. This is Dr. Dalal from Kokilaben Dhirubhai Ambani Hospital in Mumbai. I'm going to talk to you over the next 20 to 30 minutes on the importance of NOACS, that is the novel oral anticoagulating agents in the treatment of SPAF, that is the stroke prevention in atrial fibrillation. So I'm going to restrict myself to talking about prevention of stroke in atrial fibrillation. As many of you know, NOACS are also used for deep vein thrombosis, pulmonary embolism, etc. But today we are not going to discuss that. Recently, along with a lot of my colleagues, we came out with the Indian consensus document. And for those who are interested, the slides not moving. I'm just sorry, my slides not moving. I'll be with you in a minute. And for those who are interested, the article has been published in the Indian Heart Journal in December 2015. So if anybody misses out on some things I say, you could please look it up in this. As you know, stroke prevention is very important, and stroke can occur even in asymptomatic atrial fibrillation as well as in patients with paroxysmal atrial fibrillation. So it is not necessary that the patient should have continuous atrial fibrillation all the time in order to have a stroke. As you all know, stroke incidence increases with age, and almost at the age of 80, majority of patients would have some episodes of atrial fibrillation. And I think the availability of NOACS has brought back into limelight the treatment of atrial fibrillation, the diagnosis of atrial fibrillation, and its adequate treatment. It's important that people who do not have atrial fibrillation on ECG should not be mistakenly thought as having no atrial fibrillation. In order to detect atrial fibrillation, you may need to do a 24-hour Holter or a 3-day Holter, 7-day Holter, and sometimes even repeated Holter recordings over a period of weeks in order to pick up atrial fibrillation. Because it's important to remember that even a brief episode of atrial fibrillation can result in a stroke. So therefore, the atrial fibrillation neither needs to be persistent, sustained, or continuous in order to produce a stroke. So I think looking out for atrial fibrillation, especially in a patient who's already had a stroke, is very important. Simply saying that this is a stroke of unknown etiology is not sufficient unless you extensively ruled out atrial fibrillation. And as I mentioned earlier, the best way to do that is to do Holter recordings over long periods of time. A 24-hour Holter recording is not sufficient to rule out atrial fibrillation as the cause of stroke. As you know, the anticoagulation with warfarin has been very difficult to manage. The responses are unpredictable. It has a narrow therapeutic window. Numerous drug interactions take place. There's increased chance of cerebral hemorrhage with warfarin. And you also, as you can see from this, that a large number of patients will have intracranial hemorrhage even when they are in a normal INR range. So normal INR range does not mean that you will not develop a stroke or a cerebral hemorrhage. So that's important to remember. Also in India particularly, in spite of warfarin, the INR is very poorly controlled. The time to target ratio is very poor. And as you can see from this slide, poorly controlled warfarin is actually worse than no treatment at all. So many of us simply start on warfarin, have INRs fluctuating from 1.5 to whatever, 2 or so, and we feel that we've done our job, but that's certainly not adequate for these patients. If you can see from here, warfarin is one of the most important causes for patients getting hospitalized. And amongst the other drugs are oral hypoglycemics, antiplatelet drugs, insulins, but warfarin still remains as one of the important reasons for hospitalization. Asians also unfortunately do bad with warfarin. As you can see, if you look at the white, black, and Hispanic patients, and if you compare them with Asians, the Asians have a much higher chance of getting into cerebral hemorrhage as compared to those other communities. So I think those are the drawbacks of warfarin. Now, if you were to use NOACS, the question would often be asked, are NOACS going to be useful in Asians? Do they behave any differently from the white people? And therefore, fortunately, many of the NOACS have been studied in Asians, and particularly dabigatran and the big Asian arm. And as you can see from many of these trials which I have listed out here, that Asians also respond in a very similar manner to all the other participants, and the side effects also are equally same. So whatever data that you see as a sum total of the evaluation stands for Asians as well. And the same thing is there for NOACs in Asians as far as safety is concerned. As you can see, major bleeding, intracranial bleeding particularly, which is the most dangerous bleeding, gastroenterous bleeding, are all in the favor of NOACs as compared to warfarin or acetron. So I think clearly Asians also behave in the same way, and safety of NOACs in Asians is also well proved. Now, when you have a patient with atrial fibrillation, you need to decide whether this patient should be anticoagulated or not, and you have to have a chart which is called the CHADS vascular score, which is now the preferred score for monitoring decisions for atrial fibrillation. As you can see, congestive heart failure, hypertension, age, diabetes, and sex are various points have been given. And if you look at the Hasbled score, then the patient has an increased chance of bleeding as the Hasbled score goes up. Now, often the Hasbled score and stroke score goes hand in hand. As you can see, both sides have got hypertension, age, and so forth. And therefore, a person who has a high CHADS score is also likely to have a Hasbled score which is high. And therefore, even more important, the use of NOACs. Any patients with a CHADS score of 2 or more should be on anticoagulations without fail. Now, because various anticoagulants are available, you've got dabigatran, apixaban, rivaroxaban, which are already freely available. Edoxaban should soon be available, and there are many more to come. So let's go through some of the data that we have. If you look at the meta-analysis of all the NOACs put together, versus warfarin, then you can see there's a significant reduction of stroke or systemic embolization. There is a great reduction of cerebral hemorrhagic stroke, and that's the most important. Some reduction in all-cause mortality, reduction in major bleeding, and of course intracranial bleeding, most important, which is reduced. There is some evidence of increased GI bleeding, and I think that is one thing which has been a little negative as far as NOACs are concerned. If you look at Relatran, and if you look at dabigatran versus warfarin, the warfarins are all in red, dabigatrans are in blue, and if you look at GERD or abdominal pain or dysmobility, any symptoms, then they're slightly more with dabigatran compared to warfarin. If you look at GI bleeding, and you can see blue is dabigatran and warfarin is red, and if the patient has GI symptoms, there's also an increased chance of GI bleeding. So I think we need to keep that in mind when we are treating patients with NOACs. Of course, it's not just dabigatran or rivaroxaban. There's a study here with rivaroxaban again showing the incidence of major bleeding and GI bleeding, particularly over the age of 75. Most bleedings will increase with all NOACs concerned. There are various things that you can do to prevent GI problems. You can take your NOACs with meals. You can take some antacids or proton pump inhibitors. Most of the time, symptoms resolve on their own. You can use H2 blockers. So I think that's one aspect that we need to look at, and maybe we could change from one NOAC to another if dyspeptic symptoms are a big problem. Of course, patients who have bleeding ulcers or GI history of GI bleeding, one needs to be even more careful and do preventive manipulation to prevent bleeding from these patients. Now, recommended doses, as you can see with dabigatran, it is 150 milligrams twice a day with or without food. If you look at rivaroxaban, 220 milligrams once a day with evening meal, apixaban 5 milligrams twice daily, and edoxaban, which I won't talk too much about since it's not available, it's again a once a daily dose. If you have renal dysfunction, that means creatinine clearance between 30 and 49, then you need to reduce the dose of dabigatran to 110 milligrams. And that's important because it's mainly renal clear. If you look at rivaroxaban, you reduce the dose from 20 milligrams once a day to 15 milligrams. If you look at apixaban, then the apixaban dose needs to be reduced to 2.5 milligrams twice a day if any two of these following things are present. One, if the patient is more than 80, if the weight is less than 60 kilos, and if the creatinine is more than 1.5. So it's not excreted too much by the kidneys, but when you have this constellation of three things, if two of them match, then you need to reduce the dose of apixaban. Same thing is with edoxaban. Edoxaban dose needs to be half if the patient's renal dysfunction is present. And if you compare the efficacy and safety of NOACs versus warfarin in patients with low GFR, if you look at the upper column, the stroke, you can see that all drugs have equal benefit. whether you use dabigatran 110 or 150. 150 will have an equally efficacious effect as rivaroxaban or apixaban. And if you look at major bleeding, then again there is no increase in major bleeding and maybe even a slight decrease in major bleeding with apixaban in patients with renal failure. So you need to look at that, except that of course you need dose modification. So NOACs should be avoided in patients who are pre-terminal CKD, that means creatinine clearance is less than 15 ml, or those who are already on hemodialysis. In these patients, vitamin K antagonists are to be preferred. In patients with NOACs, it's also important to remember that you need to monitor their renal functions regularly, because as patient ages, renal function deteriorates. So it's not a one-off dose. Every 6 months, preferably, you need to check on renal function, especially in elderly patients or those with heart failure, because renal deterioration can occur over time and you might need to reduce the dose of NOAC. Now, as I mentioned to you, as you get older, the chances of atrial fibrillation are increased. It has clearly been shown that elderly patients benefit equally, if not more, from NOACs for prevention of stroke. So there should be no age bar for the use of NOACs in patients with atrial fibrillation to prevent stroke. In fact, I would say the older the patient, the more you should treat him, because the more chances are that you will prevent stroke. As it is, the 25% of very elderly have atrial fibrillation, and if you reduce stroke, you produce a significant reduction on the cerebrovascular morbidity and mortality of these patients. Again, you can reduce the dose. Dabigatran can be reduced to 110 twice a day. Rivaroxaban usually does not need to be reduced in elderly people. Apixaban, I already mentioned, if the age is more than 80 and either body weight is less than 60 or creatinine more than 1.5, then the patient needs a half dose, 2.5 milligrams twice a day. So if you can look at the group and look at the stroke versus major bleeding versus intracranial bleeding, if you look at the upper thing, all patients who are elderly will benefit from stroke reduction. As you can see, major bleeding is not an issue, and if you particularly look at intracranial hemorrhage, then it is significantly less with NOACs as compared to warfarin. And if you ask me what is the single most advantage of a NOAC, it is a reduction of intracranial hemorrhage. And intracranial hemorrhage is the most harmful, most disastrous side effect of warfarin or any other anticoagulation. And if we have a drug which is equally efficacious, if not more, but if it can reduce intracranial hemorrhage, then it's certainly the drug of choice. As you can see from here, that patients who have atrial fibrillation during non-cardiac surgery have an increased chance of atrial fibrillation afterwards as well. So if you see a patient who's had non-cardiac surgery, brief bout of atrial fibrillation, and then goes back to sinus, often we don't consider that significant enough. But please watch this patient very carefully, because as you can see from here, over time he has an increased incidence of atrial fibrillation, twofold increased incidence of stroke in these patients, those who have had non-cardiac surgery, atrial fibrillation. So these patients need to be followed up and if necessary treated. Perioperative risk of bleeding is increased and therefore one needs to be careful. I will talk to you later about how to stop the NOACs prior to surgery. As you know, in the past we used to do bridging by giving anticoagulation, low molecular weight heparin, for example. So we stop the warfarin, give low molecular weight heparin, then do the surgery, then restart the low molecular weight heparin, then restart the warfarin. But all those actually produces more problems and doesn't produce any benefit. So the present concept is to not do any bridging at all and to just stop appropriately the NOAC and then restart it appropriately after surgery without going into the whole business of low molecular weight. It only harms the patient without producing any benefit. If you look at the chart looking at dabigatran 110 versus 150 in the patients who required urgent surgery, there is a better benefit in terms of reduction of bleeding with dabigatran, both 110 and 150 compared to warfarin. Now the important thing is that when you decide to send a patient for elective surgery, you need to see what is the patient's creatinine, and depending on the creatinine, you need to stop the warfarin. Stop the NOAC. Now, if you look at the first chart, the apixaban, if the creatinine is normal, then you have to decide whether surgery is low risk or high risk. If the surgery is low risk, you have to stop the apixaban 24 hours, dabigatran 24 hours, and rivaroxaban 24 hours. If it's a high risk patient for surgery, high risk for bleeding after surgery, then you need to stop for all the 3 drugs at 48 hours. If on the other hand the patient's creatinine clearance is between 30 and 50 ml, then you don't need to change the stopping dose for apixaban and rivaroxaban. But as I mentioned to you earlier, dabigatran is predominantly excreted in the kidneys, so it will be hanging around for a longer time. And therefore, for low-risk patients, you need to stop for 48 hours, and for high-risk patients for 96 hours. In patients with creatinine clearance between 15 and 30 ml, dabigatran is preferably not used. If you are using apixaban or rivaroxaban, again you got to increase your stopping time for at least 48 hours. Very low creatinine clearance, of course, as I mentioned earlier, should not be on NOACs. So in these patients, you need to balance the risk, and then of course after 1 to 4 hours, and I'll talk to you again later about how to start, you can restart the NOACs. So in many patients, you don't need to give any low molecular weight heparin. You decide the type of surgery, you see how the post-op bleeding is. If the post-op bleeding is not significant or not a problem, hemostasis is good, then NOACs can be started 6 hours after surgery, and because they are quick acting, they'll have beneficial effects within a few hours. So if hemostasis is not achieved, however, you may need to wait for 24 hours after surgery before you start the NOAC. Now NOACs can be switched from one to the other. If you want to switch from warfarin to NOACs, all you do is stop the warfarin, check INR, and then when INR goes below 2, you can start the NOAC. So there's really not very great difficulty. Obviously, if the INR is more than 2.5, you hold on, check the INR again the next day, and then restart. If you want to shift from low molecular weight heparin to NOAC, you need to start the NOAC up to 2 hours before the next dose of low molecular weight heparin. If the patient is on continuous heparin infusion and you want to change to NOACs, then you start the NOACs at the discontinuation of the heparin and start NOACs. As you know, NOACs act very fast, so you don't need to start them like warfarin 1 or 2 days before. It's just a matter of few hours before the effect kicks in. If you have to switch the other way around from NOACs to warfarin, then you concomitantly administer both warfarin and NOACs until the INR is more than 1.8 or 2, and then you switch over to warfarin and monitor the INR as well. So switching from one to the other is not really a big problem at all. Now many patients with atrial fibrillation require either cardioversion or an ablation. And again, as with warfarin, you need to anticoagulate these patients for 3 weeks. Once they are properly anticoagulated, you can cardio with them. There are a number of trials of cardioversion on NOACs, and there is no problem at all. It does not increase stroke incidence or any other issues. In patients who are undergoing ablation or any other procedures, then of course you will do a TE to rule out an LA thrombus. If an LA thrombus is present, you avoid ablation. If LA thrombus is absent, you perform ablation, and then you restart anticoagulation 4 hours after sheath removal. This is the cardioversion in the RELY trial, whether you had 150 milligrams or 110 milligrams of dabigatran, and you compare that to warfarin, there was no problem at all. So cardioversion on any NOAC, there have been cardioversion trials with both apixaban and rivaroxaban, and all of them show the same thing: no increased incidence of stroke or bleeding if you do cardioversion while the patient is on NOACs. If you look at catheter ablation when the patient is on NOACs, yes, there's some chance of tamponade, about 1.3%, a very small incidence of stroke and TI. So ablation can be safely done and is being done while the patients are NOACs. If you look at the bleeding risk during NOACs, in fact, it is less than a patient who's on warfarin. So the stroke incidence is similar, but total bleeding is actually reduced by 33% as compared to warfarin. Now, can you monitor warfarin NOACs? Well, frankly, you cannot monitor. What will rise if you're giving patient dabigatran, then PTT and PT will rise. PTT and ECT will rise. However, if you're giving rivaroxaban or indoxaban, then PT will rise. However, you cannot use either PTT or PT to monitor these patients. The only time that we use these is that if the patient comes for surgery, for example, and is on NOACs and is not sure when he's taken the last dose of NOACs, you can do a PT for rivaroxaban and apixaban and a PTT for dabigatran. If the values are very high, it means that the patient has taken NOACS, the blood levels are high, and this patient's surgery should be postponed. So though we cannot use these monitoring measurements, we can use this to decide whether the drug effect is still there or not. If a patient has taken dabigatran and his PTT is normal and the patient needs surgery, it is probably safe to go ahead with the surgery in this particular patient. Now, of course, just like warfarin, patients with NOACS will bleed. They can have an accident, they can have trauma, surgery, various bleeding reasons can be there. Of course, if there is mild bleeding, nothing much needs to be done, just discontinue the dose. The good part of these NOACS is that they are short-acting, so within 12 hours, most of the effect will wear off. And within 24 hours, almost all the effect will be gone, unless the patient has renal dysfunction. Again, if you have moderately severe bleeding, then you do mechanical compression, fluid replacement. Hemodialysis has been considered for dabigatran. Of course, severe bleeding, then we'll have to give activated platelet concentrates and various prothrombin complex concentrates in order to meet them. Of course, nowadays, the antidote is available for all the drugs, particularly for dabigatran, and that is very effective. An antidote of dabigatran can reverse the effect of dabigatran within minutes, and that can be a great benefit, particularly in patients who require emergency surgery, or particularly important those who have trauma. So patients on dabigatran comes in with trauma and massive hemorrhage. The antidote would produce a removal of effect of dabigatran within minutes. And this is far better than the use of vitamin K and warfarin. When a patient comes with warfarin, we think we have an antidote, we give vitamin K, but the effect is not instantaneous. The effect will take many hours or days before the warfarin effect is worn off. So there is no real antidote for warfarin as compared to now, where there is a real, very effective, very quick reversal agent for dabigatran, and also soon to be available for the other for the NOACS as well. As you can see, these are the various antidotes available. Idureximab is available already, FDA approved. The others are in the pipeline, and you can see that one group can be effective for apixaban and rivaroxaban, and the idureximab is effective for dabigatran. There's also work in progress where a single antidote will now be effective for all the NOACS which are available. If you wish to look up more about reversal of NOACS, this is the article published in 2016 Indian Heart Journal, which gives you a much detailed view of the reversing agents for NOACS. Now, one of the things that Indians do when they treat patients with atrial fibrillation is to put a small dose of warfarin and a small dose of aspirin. So what they feel is that if you give small doses of warfarin, the patient will not have bleeding, and then to prevent strokes, you add a small dose of aspirin. But actually, that works out to be the worst combination, because what it does, as you can see from the slides, the strokes actually do not go down. If you look at dabigatran versus warfarin versus aspirin versus no treatment for total strokes, you'll see that aspirin is little benefit, warfarin is much more beneficial, dabigatran is more beneficial. But if you look at bleeding, aspirin alone has as much bleeding as dabigatran. Intracranial bleeding is as much as dabigatran. So by giving aspirin to these patients, which is what we think may be a safe course of action, is actually not very useful. In fact, it produces as much bleeding as dabigatran or any other NOAC without any significant benefit as far as stroke reductions go. So any of you who feels that I will use aspirin on my patient instead of a NOAC because the bleeding chance will be less is only fooling himself. The patient will have stroke and cerebral hemorrhage. So I think if you want to treat the stroke, then you should put them on a NOAC and not an aspirin. This is a very compelling study which looked at the same thing. It is apixaban versus aspirin called the Everest trial. If you look on the left side and you look at the incidence of stroke or systemic embolization, aspirin compared to apixaban, 55% reduction of stroke and embolism. So that's expected, but you'd expect more bleeding, but you get that? No. Bleeding is equal, major bleeding, no significant difference. More important, look at fatal bleeding and look at intracranial hemorrhage, almost identical. So if you think that you're going to prevent fatal bleeding or intracranial hemorrhage by giving patient aspirin, instead of apixaban, you're sadly mistaken. Your bleeding will remain the same, your stroke incidence will increase. Now, what do you do with a patient who has a stroke while on NOACs? It's quite possible because after all, NOACs do not 100% prevent strokes. So though NOACs will considerably, as you can see from the previous slide, significantly reduce the incidence of strokes, it doesn't 100% reduce them down. So what do you do when a patient comes to you with a stroke? First of all, if it's a hemorrhagic stroke, then you discontinue the NOACs. You may use PCC or fresh frozen plasma. And of course, the prognosis is poor, just as it was with warfarin. If you have an ischemic stroke, then you need to see when was the last time the NOAC was given. Avoid thrombolytic therapy in these patients. There are some case reports where thrombolytic therapy has been given, but I think it is safer not to give, especially if the patient has received a NOAC in the last 24 to 48 hours. You can look at PTT and PT in these patients. If they are prolonged, definitely no thrombolysis. If they are not prolonged and you wish to do because very large stroke is present, one may consider that. But I think in today's world, if possibility and availability is there, you can do mechanical recanalization and put a stent if required, and that reduces the chances of hemorrhage. Now, this is a trial where they did this is a sort of group of patients in which they looked at the thrombolysis following NOACs, and you can see that it's not very much increased if you do that, but I would strongly recommend that the papers present not to thrombolize patients who have had who are on NOACs. When should you start the therapy again? There are no recommendations for the. There is one more recommendation which I'll show you, which I think one should follow if ischemic strokes, and that is called the 1-3-6-12 day rule. Now, if you look at it, if the patient has an ischemic TIA, you can start NOACs immediately or next day. If the patient has had a mild stroke, then 3 days later. If the patient has had a more major stroke, a moderate stroke, and if you exclude hemorrhagic transformation, then you can start at 6 days. If the patient has had a severe stroke and you exclude hemorrhagic transformation, then you can start at 12 days. In patients who have massive hemorrhagic transformation of the stroke, I think you will have to judge on an individual basis. Of course, if you give a patient NOACs, the chances of the hemorrhagic stroke becoming more is possible. At the same time, you must also remember that the initial problem of the patient was an embolic ischemic stroke, which actually got converted to hemorrhagic transformation, and it was not an intracranial bleed. So at some stage, you need to reassess this patient and take the decision about restarting NOACs. It would be probably wise to start the NOACs in a smaller dose and then see the patient's response, at least in the earlier stage, till the hemorrhagic transformation is settled and stable. What about changing? As you all know that dabigatran 150 milligrams twice a day has been shown to be very effective in terms of ischemic stroke reduction. In fact, compared to 110 milligrams or compared to rivaroxaban, the stroke incidence was actually less than warfarin. Whereas with 110 milligrams and with rivaroxaban, apixaban, the incidence was non-inferior to warfarin. So therefore, there has been a suggestion that if there is no proof of this, that if a patient gets an embolus, then one might consider shifting from apixaban or rivaroxaban to 150 milligrams twice a day. But again, there is no proof of this, and one needs to look at this in great details. Secondly, one needs to also look at the patient's bleeding score, and if the bleeding score is high, then probably may not be wise to shift the patient. So the current guidelines also looking at the embolic stroke of undetermined origin, which we call as a cryptogenic stroke. I think this is the group, I think, where the patient invariably presents to the neurologist with a stroke. The neurologist evaluates these patients. Often, sometimes a 24-hour holter is done in order to rule out atrial fibrillation. But often, when nothing is found, these patients are labeled as cryptogenic or undetermined source of stroke. I think that as cardiologists and neurologists need to evaluate these patients much more extensively. Many of these patients who are thought to be cryptogenic actually have atrial fibrillation and embolic stroke. And the reason for that is that atrial fibrillation, even of a brief duration, just a matter of 15-20 seconds, or a minute or two, and those who have intermittent atrial fibrillation, that means just atrial fibrillation maybe once in a while, which will not be picked up on an ECG or a 24-hour Holter monitor, can still be the cause of the stroke. So longer duration of Holter monitoring is essential. We generally, in patients with cryptogenic stroke today, are doing at least a 7-day Holter recording. As you know, various new Holter devices are available which are not like the old time with wires and things. A little patch stuck on the chest. You can lead a normal life, have bath, etc. with this patch, and it can record your ECG for a period of 3 to 7 days. So I think most patients require this long-term monitoring of the heart rhythm before you label them as cryptogenic stroke. As you can see from here, there's a large number of patients who have this problem. Also, we have to realize that many of these patients with atrial fibrillation are going to have coronary artery disease. So there's a very common combination: age, coronary artery disease, atrial fibrillation. Many of them will require an angioplasty or PCR, and therefore you need to deal with these patients. Now, if a patient with atrial fibrillation who's on NOACS comes to you with an acute ACS, how do you decide how to treat the patient? If the patient has got a non-ST elevated ACS, and if it's not urgent, you can try and delay the angiography for about 12 to 24 hours. By that time, most of the NOAC effect will go off. So if the patient is stable in hospital, you could watch and do the angiography after an interval. If, however, the patient is presented with ST elevated ACS, then of course it is better not to fibrillate there. So just like I mentioned with stroke, thrombolysis is not a good idea when the patient has just received a NOAC. So you should do primary plasty, which is much easier and more widely available than manual extraction for a stroke. So certainly for an ACS, we need to do primary plasty. Better to use a radial approach so bleeding complications are less. It's important to remember that you need to give heparin during the procedure because NOAC does not prevent catheter thrombosis, and therefore you need to use some anticoagulation, either heparin or bivalvular. If the patient has received NOACs, it's better to avoid GB2B3 inhibitors. And if this patient has multivessel disease and both options are available as far as bypass or PCI is concerned, it may be better to select this patient for bypass because then complicated dual antiplatelet plus NOAC therapy will be avoided in this patient. Now, if a patient presents with ACS, the first thing you do is discontinue the NOACs. Then you can initiate either dual antiplatelet or single antiplatelet therapy. If, for example, the patient has a high bleeding risk or has just received this NOAC, you may start only with aspirin and add the second dual antiplatelet therapy agent after 12 or 24 hours. If you use aspirin, preferably use a low dose. And again, maybe when giving NOACs, you could consider dose reduction. Avoid ticagrelor or prasugrel because these drugs are not been evaluated with the use of NOACs. So as far as PCI with NOACs is concerned, I would stick to aspirin plus clopidogrel for the time being till more data is available. Of course, triple therapy is going to be associated with increased bleeding, and whether you see warfarin with dual antiplatelet therapy, dabigatran and whatever dose, and even with apixaban and rivaroxaban, bleeding will increase if you give a combination of aspirin, clopidogrel, and NOACs. So what we've done is we made the simplified chart. It's also available through ESC, the recent chart which comes from ESC 2015. So what we would do is if the patient had ACS and atrial fibrillation, we would assess his bleeding risk and see whether he has a low risk on the left-hand side and a high risk on the right-hand side. And then once we decide that, we decide the stroke risk. That is the stroke risk moderate or high? So in each individual patient, we decide what is the bleeding risk versus the stroke risk. And then we would look at whether the patient has got stable coronary artery disease or an ACS for each of these 4 groups. If the patient has a high stroke risk and a low bleeding score, then you could consider using dual and triple antiplatelet therapy, that means aspirin and clopidogrel, for 4 to 6 months, and then reduce it down to 2 drugs, either aspirin with NOAC or clopidogrel with NOAC. As you know, we know from earlier trials that warfarin plus clopidogrel is better than warfarin plus aspirin, but we do not have a trial as of yet to show whether aspirin with NOACs is better or clopidogrel with NOACs is better. So I think that option we still not have scientific evidence. If the patient has a high bleeding risk and a low stroke risk, then you should stop the triple therapy within the first 1 month. So preferably do not give triple therapy more than a month if the patient has a high risk of bleeding. And then after 1 year, the dual antiplatelet, the dual therapy, that means clopidogrel or aspirin with NOAC can be discontinued and only NOACs can be continued. This many people find surprising, especially interventional cardiologists, that if a patient, even if he's had an angioplasty and stent implantation, at the end of 12 months, 1 year, can be left long on NOACs alone without any second antiplatelet agent. The combination of either aspirin or clopidogrel with a NOAC on a long-term basis is associated with high bleeding risk. So you'll have to make a judgment on an individual patient. For example, if the patient is young, has a low bleeding risk, has a left main bifurcating stent, you may feel more comfortable continuing one antiplatelet along with NOACs. On the other hand, if you have a 75 or an 80-year-old patient, single stent, high bleeding chance, less chance of stroke, you should consider using only NOACs and drop the second antiplatelet agent. In our consensus and in the article in our journal, we have drawn this sort of a diagram with color coding. So if you have this diagram in your clinic, then what you could do and look at simply at this diagram. If you see green is preferred, yellow is maybe considered, and red is not recommended. So let's look at the red first. If a patient has severe heart failure, heart disease, that means right mitral stenosis, or if the patient has a mechanical prosthetic valve, then red. You do not use NOACs. If, for example, a patient has got a high risk of stroke and systemic embolism, then you can use green, which is 150 milligrams of dabigatran, or any of the other NOACs which the patient can take. If the CHADS vascular score is 2, all NOACs are equally good. If the bleeding risk is more, then there is a little more safety in the use of apixaban compared to dabigatran 150 or rivaroxaban. If the patient has got tissue valve or only mild or moderate disease, then all the NOACs can be used. So again, for a mechanical valve, no NOACs. For a tissue valve, after the initial phase of 1 or 2 months when most surgeons will give some anticoagulation, these people can be started on NOACs. NOACs can be given alone without the need for any aspirin or any other antiplatelet agents. So this is a sort of simple color coding which can help you to gauge and decide which drug you want to use. Now this is patients with more bleeding risk and renal problems. Again, this chart is very useful. Red means no dabigatran in patients whose creatinine clearance is less than 30. Which are the preferred drugs when you have kidney problems? Dabigatran 110, low dose of rivaroxaban or apixaban. If you have got concomitant platelet therapy, then again low dose of rivaroxaban, low dose of dabigatran, low dose of apixaban. Patients over the age of 80, again red, avoid dabigatran 150 milligrams twice a day, but any of the other drugs you can use. So I think this color coding helps us to decide very easily, because sometimes you can forget these combinations, and if you have this chart in your clinic, one simple glance at this chart will help you to decide about treatment of these patients. Now when we give warfarin to the patient, we often do INRs and monitorings very regularly, but unfortunately we feel that if we give NOAC to a patient, we don't need to do anything. That is wrong. NOACs are also anticoagulating agents. NOACs can produce bleeding, and you need to monitor these patients. So you need to have all the data, you need to have the planned visits. As patient gets older, more chance of bleeding. Patient gets older, the kidney problems develop, patient goes into heart failure, creatinine will shoot up, and all these patients require monitoring and change of dosages of these novel anticoagulants. So they need to be followed just as closely, though you don't need to monitor the INR, you need to monitor these patients closely. Now we all know that these trials have all been done, as you know, all the trials looked at various anticoagulating agents, but we should also see what is happening in the general public, because now all the NOACs have been available for a long period of time. Fortunately for us, we have got some real world evidence, especially with dabigatran. And the reason why we have got dabigatran is that dabigatran dabigatran was the first drug, the first NOAC to be available, and obviously since at that time that was the only drug approved in US FDA, that was the drug which was used. So the real world evidence with dabigatran is quite significant. As far as real world use is concerned for other drugs, it is being monitored and measured and being looked into, and we should soon have data for all the drugs also. This is a Medicare study from USA, and they looked at the RELY trial, which is the dabigatran trial, and they looked at the Medicare data, which is the real world data. So these were all the patients who were on dabigatran, not in any study, and therefore obviously the closeness of monitoring is less in these patients. But if you look at above RELY compared with Medicare, which is below, and you can look at ischemic stroke, you look at intracranial hemorrhage, you look at bleeding, GI bleeding, mortality, it's almost a mirror image. That means the real world data is almost the same as the trial data. That's very, very reassuring. Look at another trial, another real world data, the DOT warfarin watching versus the RELY. And again you see above is the RELY trial, lower is the real world data, again almost a mirror image. The big advantage, as you can see, is there is a benefit from stroke. Very important, look at intracranial hemorrhage, significantly less. Look at major bleeding, significantly less. So it's very important that we have real world data to show this. And the last real world data comes from UL Health Insurance. Again, very large number of patients. Look at the number of patients, 44,000. And look at the data. It's wonderful that all the data is clearly in the same direction. Whether you look at the trial data or any of these three real life observational data, you'll see the same thing. Reduction of stroke, reduction of major bleeding, reduction of intracranial hemorrhage. So again, it's very, very reassuring to know that NOACs in general have been very safe and preventive. So I think I've taken you through some of the data on NOACs. Obviously the data is vast and I can't take you through all the possible combinations and permutations. I'll give you some simple points on what to do if the patient goes for surgery, how long to stop the NOACs when the patient goes for surgery, especially if the patient's got renal dysfunction, what you should do when a patient has stroke, to restart the NOACs when the patient has stroke, the 1, 3, 6 and 12-day management, what to do when a patient has myocardial infarction, that you should avoid thrombolysis, that you should avoid prasugrel and ticagrelor, that you should use dual antiplatelet plus NOACs for a shorter period of time, and after 1 year most of the patients can be on NOACs alone. Do not use NOACs for mechanical valves, but they can be used when there is only mild valvular dysfunction or when there is a tissue valve. When the patient has bleeding, you have now antidotes available which are extremely effective. Within minutes, they will reverse the effect of dabigatran, apixaban or rivaroxaban. More data will be available, more research is being done on these antidotes. You're also going to see more and more NOACs as well. And eventually you will make your own decision as to which NOAC you prefer. My personal feeling that all NOACs are equal. Some NOACs do have little benefit in terms of GI complaints, others have benefit in terms of coverage in elderly patients, some have got benefit in terms of stroke reduction more than warfarin compared to others. So I think you need to understand all these points and treat patients accordingly. I would like to end by saying that what is probably most important is to diagnose patients with atrial fibrillation. Do not miss patients with atrial fibrillation. Once you diagnose a patient as atrial fibrillation, it's extremely important that you treat these patients. Do not look upon them lightly because they will have a stroke that can be prevented. A stroke that can be prevented with a drug which does not produce intracranial hemorrhage to as great an extent as warfarin used to do. And patients who come to you with stroke go all out to find out whether they have atrial fibrillation or not. Besides NOACs, you have other therapies like umbrella closure of the atrial appendage, and that can be done as a means in patients who have bleeding or other issues on NOACs. You could use a mechanical closure device of the atrial appendage, and that would reduce your chance of need for NOACs. So I think I've covered up many points. You can read up the other points. We still have time if you wish to discuss. So I'll go ahead and take your questions, and I'll try and answer as many questions as possible, depending on how many questions I have. Thank you very much indeed. I'm trying to read the questions. Unfortunately, they're coming through very narrow. My mother went through cardio version 15 days ago, which was 1.5 years after cardiac ablation. she has been prescribed rivaroxaban now along with flecainide. Please share your opinion. So she has had ablation and a cardioversion, and ablation does not mean that the patient will not require NOACS forever. So I think ablation patients sometimes continue to have atrial fibrillation. You need to monitor them long term. There is a bit of debate as to what we need to do for patients who are free of atrial fibrillation after 1 year of ablation. Certainly during the first year they require to be on NOACS. Once you ablate the patient, then you need to constantly monitor them over long periods of time. If the patient has any episodes of atrial fibrillation, in spite of that, the person needs to be on NOACS. Again, the use of rivaroxaban, apixaban or dabigatran depends on various factors. My personal preference is if the patient has got significant renal dysfunction, then either avoid the use of dabigatran altogether or reduce the dose down, and then use half doses of either apixaban or rivaroxaban in a smaller dose. But I think they need to be continued on anticoagulation. Next question. What are the chances of stroke even after dabigatran use? As you can see, the incidence of stroke depends on the JADS vascular score. And from the JADS vascular score, it shows that it can get a stroke incidence of anywhere from 2 to 5 or 7% per year. Various annual anticoagulants will reduce the chance of stroke by more than 50 to 60%. So therefore, there is a significant reduction of strokes, but it doesn't become zero. So I think you need to keep that in mind, that the advantage of dabigatran and any other novel anticoagulants is that you can reduce the incidence of strokes without the hassles of the INR monitoring and with a significant reduction of overall bleeding and a very significant reduction of intracranial hemorrhage. Dr. Dalal, your comments on high price versus benefits of treating patients, especially in primary or secondary healthcare centers. Of course, cost is an issue. There is no question about that. These are very expensive drugs. There are two things you need to keep in mind. One is when you talk of expense, obviously the immediate expense is there. The patient cannot afford a tablet because it's so expensive. There's nothing you can do about that. But if you have to look at an expense in an overall manner, then you have to look at the expense of the INR monitoring, the expense of the patient going to do the INR monitoring, the expense of the patient coming to see the doctor to show the INR monitoring. So all that must be counted in the expense, not the cost of tablet versus tablet. Secondly, if you were to have a cerebral hemorrhage, for instance, or if you have to have an increased stroke, then you have to add this cost of the hospitalization for stroke and hemorrhage as an additional cost. So I think if you look at cost of one tablet versus the cost of the other, of course there is no question, it's much more expensive. If you look at the overall cost in terms of cost for stroke admission, cost for cerebral hemorrhage admission, then the INR monitoring cost, then maybe the cost values will come more in favor of NOAC. Again, I am very hopeful that as more and more NOACs come, and as competition increases, the chances are that the cost per se will come down. And I think once, of course, patent of the drug goes up, the cost will dramatically come down. So we are hoping that the cost factor does become. I would like one practical point that which I have seen in patients is that sometimes because these drugs are expensive, they tend to stop the second dose. So when you prescribe them twice a day, they might take only once a day thinking that they will get half the benefit, but unfortunately they don't get half benefit, they get very little benefit. So please do ask your patients and try and convince them that it's important to take twice a day. Because when you ask them, are you taking the medicine? They say yes, but then when you go deep into it, they say, we take only once a day. So please look into that. I've seen that problem with some of my patients. What are the chances of stroke in spite of, please answer that. In spite of, and, sorry, go back. Whatever the, yeah, so there's a question here on use of metoprolol in atrial fibrillation. Yes, I think beta blockers are very useful in the treatment of atrial fibrillation. especially post-cardiac surgery, post-bypass surgery. It certainly reduces the chances of atrial fibrillation. And I think it's important to reduce atrial fibrillation, because if you reduce atrial fibrillation per se, the chance of stroke will be less, and therefore the patient's benefit from a NOAC will be less, because obviously less the atrial fibrillation, less the embolic chance, and less the patient getting a stroke. So I think besides NOAC, all attempts should be made to reduce atrial fibrillation, whether it is with drugs or whether it is with ablation.
You can take this into questions.
Fibrillation, how long we should continue NOACs? Well, basically, you are giving NOACs to prevent stroke, and therefore the NOACs have to be continued lifelong. Now the question comes that if the patient has persistent AF, then there is no difficulty. You have to continue lifetime. This problem only comes if the patient has got intermittent atrial fibrillation, or the patient has had an ablation, or the patient had atrial fibrillation after some form of surgery, bypass or otherwise, and for quite a few months had atrial fibrillation. Then the patient was put on treatment, including NOACs, and now a year has gone by and the patient has got no atrial fibrillation. That is a difficult question. But then it's up to us to evaluate a number of things. I think you look at that individual patient. What is his age? What is the chances of him bleeding? What is his CHAS vascular score? And then take a decision. If the CHAS vascular score is high, I would continue with atrial fibrillation treatment with NOACs. You also have to see whether the atrial fibrillation has completely stopped because it was induced by some problem, or it is continuing. Minimally, you should do a 7-day Holter recording, and you need to do it more than once. So maybe over a period of a few months, you repeated 7-day Holter recordings. If none of them show atrial fibrillation, if 1 year has gone by since the last atrial fibrillation, the atrial fibrillation was induced by an acute episode of something and has not been happening again, then one may consider stopping NOACs. But otherwise, if any atrial fibrillation is detected, patient not being symptomatic is not a criteria. Asymptomatic atrial fibrillation has a similar incidence of stroke as the symptomatic atrial fibrillation. The symptoms in atrial fibrillation depend more on rate and other problems of the patient rather than on the atrial fibrillation person. So I think we'll have to individualize the patient, but chances are that these patients are all going to be on lifelong NOAC therapy. What is the effective treatment guidance on treating hemorrhagic stroke in atrial fibrillation? Hemorrhagic stroke while the patient is on NOAC is a big problem. Or if a patient is not on NOAC and gets an hemorrhagic stroke, then if it's not an ischemic stroke with hemorrhagic conversion, it's a primary intracerebral hemorrhage, then do not use NOACs. And then if the patient has atrial fibrillation, then you have to talk of mechanical. Do ablation, do closure of the atrial appendage. So you have to go with mechanical means, because in a patient who's had cerebral hemorrhage and who's got atrial fibrillation, using of NOACs is fraught with danger. Think of other ways to prevent the atrial fibrillation from occurring. I think we are now at 4 o'clock. I think we have answered most of your questions. I don't see them here. Any other questions there? So I think we've answered all your questions. We've had a good 1-hour session. I've enjoyed talking to you all. I hope you have been able to understand many of the things that I mentioned about NOACs. There's also considerable new data coming out in NOACs, and I think we'll have to continuously read about these things, because every day something new comes out. There are more subtle investigative changes which have been looked into. There are registries and real-world data which is coming into it. And for each of you, I would suggest that you get to know a particular NOAC. I think you should know all the NOACs, because each one does have subtle differences from each other. So overall, yes, all NOACs will do the same thing. I think each NOAC has a different appeal. Some are single time use in a day, some are twice a day, some are kidney excreted, some are not, some are little less hemorrhagic, some are little more GI problems. So you do have these subtle differences, and you can choose a NOAC for a particular patient if you wish. However, it's also at the same time important that you have a good hold on one particular NOAC, especially which was your favorite, and then you can use the other NOACs depending on the patient's condition. So I think we'll end now. Thank you very much for participating in this webinar, and look forward to the next webinar. Thank you very much.
Thank you, Dr. Jamshed Dalal, for taking this webinar session on stroke prevention and atrial fibrillation. It was really an engaging and insightful talk, and we hope all the participants enjoyed the session. If there are any more questions, please write to us at editor@ethealthworld.com. The recording of this webinar will be made available on ETHealthworld by tomorrow. Thank you everyone for joining this webinar. Signing off.
Thank you.